Let's begin. Hello everyone, welcome back to the series of lectures in nephrology. This is Dr. Maitreyi. So in the last session we have learnt about sodium disorders where we have learnt about hyponatremia. Today we will be learning about hypernatremia. Okay. So we know that the normal serum sodium, how much is it? It is between 135 to 145 milliequivalents per liter, right? So anything above 145 milliequivalents per liter is what we call as hypernatremia. So let us look at the etiologies of hypernatremia. So what are the etiologies of hypernatremia? It can be because of gain of sodium. It can be because of gain of sodium, which includes because of hypertonic saline. Let us say when the patient is of hypernatremia having hypertonic saline treatment, or a patient of head injury is getting 3% NaCl for his head injury. So then saline dialysis. So whenever the patient is undergoing dialysis with a hypertonic fluid like 3% NaCl, right? So whenever a patient is undergoing dialysis with fluids like 3% NaCl, then use of hypertonic feeds, all of this can result in hypernatremia. Then mineralocorticoid excess. We had learnt in our chapter on hyponatremia about what happens when there is a mineralocorticoid deficiency, right? So which is your mineralocorticoid? It is your aldosterone, which is responsible for the reabsorption of sodium and water from the kidney. So what happens is that whenever there is mineralocorticoid excess, what happens? There is more reabsorption of sodium and this can result in hypernatremia. Then the second cause will be because of there is loss of water in excess to the sodium. So this can happen in renal causes or non-renal causes, right? So this can happen in renal causes or extrarenal causes. The renal causes will be diabetes insipidus. Renal causes will be diabetes insipidus. This is a condition which is characterized by excessive water output or urine output more than 3 liters per day, right? So this can result in hypernatremia. Then the use of diuretics. We know that diuretics can cause hyponatremia, but if diuretics are used so much so that there is a lot of dehydration, then what happens? The patient starts having hypernatremia because of dehydration, because of loss of water in excess of the sodium loss. Okay. Extrarenal causes can be from the GI as well as the lung. Okay. Then the third mechanism of hypernatremia happens when the thirst center is impaired. So the third mechanism by which hypernatremia happens is that this happens when the thirst center is impaired. Okay. So what happens when the thirst center is impaired? Where is the thirst center? We have learnt in our chapter on osmoregulation. Thirst center is in the hypothalamus, right? So whenever there is an problem with the hypothalamus, the thirst center gets impaired. So this can happen in psychogenic cases or it can happen in certain central conditions like an infection, a tumor, infiltration. So if the hypothalamus is impaired, thirst center is impaired, the patient becomes adipsic. He does not take enough water. The patient becomes adipsic. He does not take enough water and this is what results in hypernatremia. Okay. Then altered mental status. Now, the patient is not in a situation to take water at all. So, that can result in hypernatremia. So, a patient of Parkinson's disease, a patient of stroke, a patient of severe psychiatric disease, he is not taking water at all. So, then this can result in hypernatremia. So, this is about your mechanisms and etiologies of hypernatremia. So, hypernatremia can be because of gain of sodium, it can be because of loss of water or impairment in your thirst mechanisms. Okay. So this is about your etiology. Now let us look at the approach to hypernatremia. So what are we seeing? We look at the ECF volume first. Similar to your approach to hyponatremia, here also we basically do the volume status examination. So what we do? We look at whether the ECF volume is increased. How do we look at it? We have already seen in your chapter of hyponatremia. You look at the JVP, you look for pedal edema, you look for bibasal crepitations. Right? So once you find out, if you find out that the ECF volume is increased, Then if the ECF volume is increased, it can be because of administration of hypertonic saline, it can be because of administration of sodium bicarbonate. Sodium bicarbonate treatment is used in the management of what? Is used in the management of metabolic acidosis. So inadvertent excessive use of saline or sodium bicarbonate can result in hypernatremia. If the ECF volume is not increased, patient is not in a volume overload state, then you see what is the urine osmolality. Right? You see what is the volume of the urine and you see what is the urine osmolality. Okay? If the urine is concentrated, means what? Kidney is able to do its function. That means this is because of an extrarenal cause, because of a GI loss or insensible water loss. Right? If it is not, then you look at the urine osmolality. If the urine osmolality is low, that means what? There is diabetes insipidus, isn't it? Just now we had discussed what is diabetes insipidus. There is excessive loss of water, right? So there is excessive loss of water in volumes of greater than 3 liters and there is passage of dilute urine. So if the urine osmolality is low, it means that you are dealing with diabetes insipidus. If urine osmolality is high, then it can be because of a diuretic induced. Hypernatremia. Now, once you have diagnosed that this is a diabetes insipidus, then you see your response to desmopressin. Okay, if there is a response, desmopressin is what? Desmopressin basically helps in concentrating the urine, right? So then the urine osmolality increases to desmopressin. Then this is a central diabetes insipidus. Central diabetes insipidus means what? There is a problem at the hypothalamus or at the pituitary. There is a problem at the hypothalamus or the pituitary. So central diabetes insipidus means what? There is excess amount of urine in more than 3 liters per day. Dilute urine is being excreted. Why is that happening? Because of a central cause. Any problem with the hypothalamus or any problem with the pituitary. Mainly because of infections, infiltrations, trauma, tumor, it can be anything. We will be dealing in more details in your chapter of posterior pituitary. Okay. Now, in your response to desmopressin, now you give desmopressin, what are you expecting? The urine osmolality should increase, but it has not increased. That means there is a resistance to the action of desmopressin. Resistance to action of desmopressin because of problem with the vasopressin or desmopressin receptors. So this is your nephrogenic DI. Okay. So till now what have we learned? We have learned about the causes of hypernatremia. We have looked at the approach to hypernatremia. In your approach to hypernatremia, first step, always do a volume status examination. If the patient is hypervolemic, that means he has pedal edema, he has elevated JVP, he has bilateral crepitations, that means that it is because of an iatrogenic cause. We have given him excess IV fluids or we have given him excess sodium bicarbonate. If it is not so, then you see whether he is able to pass a well concentrated urine. If he is able to pass a well concentrated urine, then it can be because of a GI loss. If he is not able to do so, that means that there is large amount of urine that is going out. Then you look for the urine osmolality. If the urine osmolality is high, that means something else is pushing. It can be because of a diuretic induced or an osmotic diuresis. Okay, but if he is passing large amount of urine, it's not concentrated and the urine osmolality is also low, then we are looking at diabetes insipidus, right? Now, once you have found out that you are looking at diabetes insipidus, you see whether this is your nephrogenic or your central DI. So, nephrogenic DI, there is no action to peripheral desmopressin. The urine osmolality remains unchanged because there is a resistance. In central DI, the urine osmolality increases with desmopressin challenge test. Okay, so this is about your approach to hypernatremia. Now, let's move ahead. Right, so what are the clinical features of hypernatremia? Similar to what we had seen, if there is hypernatremia, then the fluid starts moving from the intracellular to the extracellular space. This means that what? The cell begins to shrink. So, which cells are most affected? It is your nervous cells. Then what happens? There will be confusion. right? There will be lethargy and they can also have seizures. So predominantly CNS manifestations are the manifestations seen with hypernatremia. Okay, now let us look at the management. How will you investigate? It is the same way. You see your serum osmolality, urine osmolality and your serum and urine sodium. What is the fluid of choice? If you have gone back and seen the chapter on IV fluids, what is the fluid of choice? The fluid of choice will be your half NS or your 5% dextrose, right? But if you use your common sense, what will you think of? Now patient has hypernatremia, right? But what is hypernatremia due to? It can be because of excessive water loss as compared to the sodium. Then what you have to give to treat the hypernatremia? You give him water, right? You give him water. So oral free water. How will you give that? Now the patient will be having CNS disturbances, right? Do you think he will be able to drink water? So what you will do is you put in a Ryle's tube and you keep giving him free water through the Ryle's tube. Okay. So many a times there are patients of maybe Parkinson's disease or stroke who have not been eating properly, right? And they may be their fluid intake is also very less. So in these patients, the best treatment would be to put in a Ryle's tube or an NG tube, which is your nasogastric tube, and you give them feeds through that and you give them free water to that. So that will be your first step. After that, you resort to your IV corrections. After that, you resort to your IV corrections. So two fluids which can be used is your half NS and your 5% dextrose. Why are these two fluids used? Because 5% dextrose basically when it breaks down, the dextrose becomes carbon dioxide and it is removed out. Okay. So what are we left behind? We are left behind is water itself, right? So what we are left behind with is water itself. So the water is then distributed through all the three compartments, which is your intracellular, interstitium and plasma. That is the reason why 5% dextrose is a very good choice for treatment of hypernatremia. What happens in 0.45% NS or half NS? Again, half NS is nothing but your 0.9% saline along with extra 500 ml of water. So this extra 500 ml of water can replenish your intracellular space. Why don't we use 0.9% NS in the management of hypernatremia? Because 0.9% NS, as you have learned from your basics of IV fluid, it restricts itself to the extracellular compartment. So it cannot be used for replenishment. Okay. So let us look at the management of hypernatremia in more details. So first step would be you calculate the water deficit. So you estimate the total body water. Similar to how we had estimated the total body water in your management of hyponatremia, here also you have to estimate the total body water. So this is given by 50% of body weight in women or 0.6, which is 60% into body weight in men. Okay. Once you have done that, you use your formula, which is your sodium minus 140 by 140 into total body water. So which is the formula that you are using here? So to calculate the free water deficit, you use your sodium minus 140 by 140 into total body water. Right? So you administer the deficit over 48 to 72 hours and you make sure that you follow the same rule. You do not increase the sodium to more than 10 milliequivalents per day. Okay, because of the fear of osmotic demyelination syndrome. Alright. Apart from that, you also have to replace ongoing water losses, right? Somebody of diarrhea, somebody will be having excessive sweating, so they can be insensible water losses, right? So that is obtained by your calculation of free water clearance, which is given by volume of urine into 1 minus urine sodium plus urine potassium by plasma sodium. Okay, so this is to replace the ongoing losses and add some amount of insensible loss as well. So once you add all these calculations, this is the amount of fluid that you will have to administer. Either your 0.45% NaCl or your 5% dextrose. Okay, fine. So that brings us to the end of this chapter about hypernatremia. So what all have we learnt now? We have learnt about what are the causes of hypernatremia and how do you manage hypernatremia. Okay, thank you.